ACS, or acute coronary syndrome, is a spectrum of coronary artery disease that's caused chest pain per se. And this can be something that causes the patient to have this type of chest discomfort with multiple other symptoms, and it could be causing decreased blood flow to the myocardium or heart. This can result in something that's even further on down this spectrum, where we have angina, which is this blockage that temporarily is resolved, to where it's completely obstructed in the myocardial infarction. Now we'll talk a little bit later about what's called a STEMI, or ST elevation MI, but let's go back to the heart itself. In ACS, or acute coronary syndrome, these blood vessels that branch off the base of the aorta, the right coronary artery and the left coronary artery, these supply blood to the heart muscle. So again, they come off the base of the aorta and they supply blood to all of the heart muscle and myocardium, and they penetrate from the outer layer, or the epicardium, go through the middle layer of the myocardium, and all the way through to the endocardium. Now, as you can tell, if we open up this this type of display, it'll show you other features that are anatomically placed in the heart, and these require this blood flow in order for them to continue to function and survive. So let's just say a blood vessel that is obstructed on the right coronary artery that seems to apply to most of the right, the atria and the right ventricle, and it seems to float around towards the back, and then down here on the inferior surface. Anytime that this blood vessel is obstructed, it can cause some damage. It can cause damage to the papillary muscle that holds this chordae tendineae that keeps these valves closed. So if the valve now is open, it's a result of the poor perfusion or lack of blood flow or circulation through that blood flow from the right coronary artery affecting the right ventricle. All right, so just for example, when we have this obstruction in either the right or left coronary artery, it decreases the oxygenation and nutrients needed for metabolism for the heart to function. As a result of this, the person then describes chest pain, and this chest pain is described more of like a pressure type pain, something almost similar to indigestion. It's not necessarily pains for some people, it may be just a vague discomfort, like a weight or pressure sitting on their chest, and they may make this clenched fist sign or Levine sign over their chest, indicating that they're having such. Other associated signs and symptoms may be some shortness of breath or dyspnea or difficulty breathing. They may also break out in a cold sweat, and they become very diaphoretic. They may also become a little nauseated, feeling like they have to vomit, or they may vomit all along by themselves. Now this may also affect their pulse rate, so they may have a period where they felt faint or lightheaded, and it may also affect pacemaker sites such as the ventricles or the SA node, causing arrhythmias. So arrhythmias are things that cause an electrical disturbance, causing the heart to malfunction in such a electrical way, manifesting then in a mechanical way. So just again, for us to recap, these coronary arteries that are supplying blood to the myocardium become obstructed. They become obstructed as a result of plaque. This plaque formation is a result of fat deposits from bad cholesterol being placed within the opening or the lumen of that arterial wall. As this plaque develops, this plaque can then continue to obstruct 100% occlusion, or it can break off and then it floats as an emboli, obstructing smaller arteries distal to where that clot was formed. In any event, once the blood vessel is obstructed on the myocardium, the patient then will describe some type of discomfort somewhere in the chest. Now let's go over onset. So this is all of a sudden onset of description of symptoms. It's usually provoked by some type of exercise or some type of activity. But if in the later cases where they have an unstable heart condition where their blood vessels are pretty much obstructed, this can come on even at rest. What makes it better is usually when they take their time to sit down and catch their breath and rest a little, or if they're using nitroglycerin, this is placed under the tongue, which causes the dilation of these arteries to allow blood flow to circulate around that obstruction. The quality, usually as we talked about it, it's a severe pressure or squeezing type pain or discomfort, like an elephant sitting on their chest, or something like vice grip over their chest or indigestion. Severity. It's up to the patient's tolerance. So this severity could be from 0 to 10. And we want to gauge this based on how much we've done to make it better. So if we're giving them the rest, we're giving them the oxygen, and we're having them take their nitroglycerin, we want to see the pain reduction in this. T, time is basically our time of the event, so the entire time. And we have a specific window. We have about 6 hours to get them to the hospital so that we can administer clot busting medication, where we take the medication and it causes the clot to be dissolved, thereby opening that artery and then allowing blood flow back to the myocardium. Now, in angina, this is usually resolved easily, and they may have multiple episodes, but this is the precursor, a telltale sign that they have coronary artery disease and are going to require to see a cardiologist to treat their coronary artery disease. In some cases, it's very mild, where the nitroglycerin is taken infrequently. In some cases, angina becomes more and more frequent, where it's unstable. This means that their medications no longer cover the exertional stress and oxygen supply to the heart muscle as a result of the coronary arteries continuing to be obstructed. It is into a point where they do the other tests to evaluate the blood vessels on the heart through the coronary circulation and determine that they might need something called stenting, angioplasty, or coronary artery bypass graft. If undetected early, the patient then can suffer something that's called a myocardial infarction. Now, myocardial infarction is where the actual heart muscle, as a result of poor, inadequate blood flow because of the obstructions of the coronary arteries, this heart muscle is dying. And as a result of that heart muscle dying, this heart muscle does not regenerate itself. Now, in the most classical sign, we would see an ST elevation. It's because the artery that's blocked is so high up that it's obstructing blood flow all the way from the epicardium through the myocardium and into the endocardium. It's a transmural. It went right through all 3 layers of the heart, giving us an ST elevation. In the patient without the ST elevation, or just some kind of ST depressions, where it's not an elevation, where it's not an acute STEMI, this may be a blockage somewhere in the myocardium itself. It could be a myocardium, and it could be on the endocardium, but somewhere else. It's not a transmural infarction. Nevertheless, the heart muscle will start to die, and as a result, it leaches out its own chemicals, which we call troponin and CKMB. We'll end up finding these in the blood, and we'll then monitor and serially take these blood values to determine whether or not the myocardial infarction is continuing on or is it stopped. Again, they have similar symptoms. Go back to your OPQRST. These patients may also have other comorbidities or significant medical history or risk factors. This would be age, diabetes, smoking, hypertension, obesity, part of our metabolic syndrome. Please review ACS, the acute coronary syndrome, and the spectrum of chest pain from angina, unstable angina, myocardial infarction, both the ST and non-ST elevation MI.